Okay, Rebecca Segraves, I am really excited to have this conversation with you. And if I could just really quickly set the stage here, I found your clinical commentary because I was asked to give a presentation to some other physiotherapists and midwives in a different country on how we as physiotherapists are involved in preparing people for C-section and recovering. And I wanted to do a bit of a search on the most recent research and literature to see kind of what's going on around the world. And that's when I found your clinical commentary. And I'm fascinated by what the work you're doing. And I can't wait for you to share everything that you've been up against, because I imagine this has been a ton of work for you. And so before we even start, like, thank you on behalf of everybody involved for all of this hard work that you do, because I think it's people like you, obviously, that start the ball rolling for change.
Well, thank you so much for having me. Yes.
So before we
Um,
get started, will you tell everybody a little bit about who you are? Where are you? A little bit about who you are, and then let's get into your work.
okay. Yeah. So I am a pelvic health therapist by background here in the United States, now in Washington State. And I completed a residency in women's health physical therapy in 2016, excuse me, at Duke University. So on the East Coast of the United States. And at the time I wrote that commentary in 2020, I was living in the central time zone in Texas and working at a very large hospital system that was what's considered, say, a trauma level one or the highest care facility for the most complex maternal and neonatal cases. So it's a perinatal care facility that really saw the most complex of the complex mothers who needed to have surgery while they were still pregnant. And so I would see these very long incisions from one side of the pelvis to another on a mother who was 25 weeks pregnant and still having to carry her baby to term. So I would see this closed incision and knowing that she would have to have a C-section on that in 10 weeks or so. I mean, those were very, very complex surgeries, but inpatient care was not my background. When I finished my residency in 2016, I actually practiced in pelvic health outpatient and primarily with oncology. And so, readily from residency, I saw a bit of imbalance in care where we were essentially waiting for people after mastectomy or hysterectomy to develop all these problems, whether it was lymphedema, whether it was chronic pain after they had gone through radiation, after they had gone through, multiple surgeries, whether to remove more lymph nodes or just chemotherapy. And it didn't make sense to me. And so I developed a program in outpatient pelvic health where we were seeing mostly women after cancer-related surgeries and treatments. And I said, after every surgery, I want to see someone after this procedure, whether it was a lumpectomy to a mastectomy or hysterectomy, no later than 2 weeks. And so that was this work has been quite significant, but that work was it was an overhaul because I had to literally change the culture of our physicians who felt like there was no need to send someone after a mastectomy that early to physical therapy. And I said, absolutely, there's a need because you're going to radiate that tissue. And then we've lost any gains that we could have in range of motion at that point, because now that person has not been taught how to actually range their arm before you start radiation. So that was a lot of education. And I really brought that concept into obstetric care when I started in the hospital in 2020.
Interesting. And so in 2020, you start working in the hospital and you start noticing some of the same, some parallels with, people after C-section. And I think I really loved how you pull out of that clinical commentary all the things that we do as I'm going to use the term physiotherapy and physical therapy because we just refer to ourselves as that in Canada. But will you talk a little bit about, because I think a lot of people listening, I mean, physiotherapists know this, but other people listening don't necessarily know our involvement in acute care. we are there day one after some pretty big surgeries in the hospital. And I like how you pull that out, make parallels to we are involved and we have funding in the hospital for all these other reasons. Will you talk a little bit about that?
Sure. And so the commentary really was written at the end of 2020 after I've had nearly a year with this population and just a year to acclimate to the culture. And I had worked in a hospital as a physiotherapist before. I'd seen people, within the first 12 hours after a knee replacement or a hip replacement, seen the effects of anesthesia. I've seen the effects of labile blood pressure issues that, just made them too unsteady to send home. And so when I started in the hospital, with moms after cesarean section, saw those same issues. I saw people who were not ready to walk around their room and carry their baby safely. I saw people who were at risk of falling. I saw women who could not stand in the shower and they didn't have a shower seat at home that they were going to be returning to. And also they had flights of stairs. Some of our moms were in townhomes or apartment homes where they would need to negotiate those stairs before they even entered their home. And we were ready to send them out on day two. And so the commentary was really written in a response to that experience. And when people, have been searching for evidence, they were in the same boat as I was. I didn't have anything to really guide me as an outpatient pelvic health coming into this setting. So I was on the computer looking for articles that could guide me and give me evidence. And I was really at that point, unfortunately neglecting what evidence-based really was. And it's three tiers to evidence-based. It's the patient experience, it's the clinician's expertise, and then it's what's actually getting published in journals. And so I was looking for what was getting published in journals to guide me and really forgetting, wow, I had a year of seeing a patient's experience and knowing my own clinical expertise from other similar procedures that I've treated people after. So really that commentary was a response to care neglect for women after C-section. And so a lot of what we'll talk about is really what I've put together that will guide therapists, especially those who work in the hospital setting and those who are fortunate to see this population within the first 6 weeks after surgery.
Yeah, I too have worked in, a large trauma hospital where I have, worked in intensive care. I've been involved with people day one after open heart surgery, orthopedics, like you said, hip, knee, abdominal surgeries, hernia. So you just think of a couple inches above, they get to see a physiotherapist. But if there's evidence to support all of that and those guidelines, obviously, there has been studies to show that whether it be less complications, earlier time for discharge, less rate of infection, all of that, there are reasons that there's funding for physiotherapists in that acute setting. But sometimes we just don't make those parallels to, well, what's the difference between that and cesarean birth? And especially when you make the point that cesarean section is the number one surgery that's done in the United States. I'm guessing that's actually in Canada as well.
I would agree. I think in North America it does surpass most of the routine procedures that we as physiotherapists would see someone typically after. And so because of how big of a gap it is between those more common surgeries like hip replacement, knee replacement, I would agree that it is the same in Canada as well. And one thing about the commentary, the reason why it came to be really was in 2020, we had a huge change from ACOG, which is the American College of Obstetricians and Gynecologists, where their response to the COVID-19 pandemic was to send mothers home earlier from our hospital settings to really mitigate any risk they had to COVID-19. And I was in a large metropolitan hospital at that time, seeing well over 500 births a month being delivered. And so because of their guidelines, we saw mothers who were normally able to stay in the hospital until day 3, day 4, now being sent home on day 1 or day 2. And as physical therapists, we were not able to even see them within the 4 day time frame that they were in the hospital. And now we had 2 days where discharge was the priority over patient function. And so I had to really be quite swift in advocacy. It took about 6 months before we were able to have orders so that every mother after cesarean section had an automatic physiotherapy evaluation before she was discharged from home. And that was a huge undertaking, but that was really what culminated into me writing the commentary.
How did you go about doing that? And again, I will acknowledge that our healthcare system is different than your healthcare system. I'm curious to know, though, where did you start that process? When you say 6 months of kind of advocacy and communication, what did that look like, and who was that with?
So I go back to the 3 tiers of evidence-based practice. And what I was doing at that time was I was looking online for articles that could guide me because I really didn't have much experience in the acute care setting. I was an outpatient-based physical therapist. And so I didn't find much. And so the patient experience that I started to really communicate with the physician groups that I was in close proximity to, I was lucky and fortunate to really be in the hospital setting where I could grab someone from a maternal fetal medicine team or one of our urogynecologists and really talk to them about what I was seeing. And so our patient experience really, I had to start tracking outcomes. And in the span of 3 months, I was able to show physicians 3 separate patients who were all primary cesarean delivery. That means they were first time moms and first time cesarean section, obviously, first time major surgery. And they all, at different times over that 3 month period, were readmitted to the hospital. Why? They were readmitted for their cesarean wounds dehiscing, opening up. And their length of stay after readmission was on average 9 days. So they were sent home after ACOG released their guidelines in May of 2020. They were sent home within 2 days, not 4. They weren't really properly evaluated for their mobility, for their ability to get out of bed without using hospital rails, for their ability to move around holding their baby, even for their ability to negotiate stairs if they had an apartment. No one asked them those questions. So they were readmitted and now had a 9 day average length of hospital stay. And I had to track those outcomes by myself and go to the physician that was the primary physician at that time of their delivery and present outcomes that were very uncomfortable to be reminded of. And really make a pitch at that point, a pitch to say, if you allow me within the first 24 hours to do an evaluation to see what their home environment was like, what their support system was like, if they were a single mom, if they had other children at home, do a really appropriate ethical based evaluation. We may not see outcomes like this in the future. And so it was really a trial base. I had to get orders. I had to go to, the room after delivery, offer my services, have an affirmation, yes, from mom, and then do that, and then start gaining momentum from there until it really caught on like wildfire.
That's interesting. And so, yeah, so then I'm curious to know, what did that look like? If I want listeners to be able to picture that, because this is foreign for people to be, and a lot of physiotherapists listening, there are a lot of physiotherapists that listen to this, haven't worked in the hospital setting. They would have had to in their clinical placements in school, but that might not be where they're practicing at all. And they might be outpatient physiotherapists that are not seeing these postpartum women until 6 weeks minimum and or far. So sometimes it's hard to picture what that might look like in the hospital. Can you describe in kind of those preliminary stages, what did your interaction look like? Like really kind of, you've already mentioned, I asked them what their environment looks like, but what kinds of things would you go over with them?
Sure. So I would typically come into a room and I'm thinking as an outpatient pelvic health therapist, I want to prevent someone having chronic pain. I want to prevent a wound from opening up prematurely or at all, really. I want to prevent incontinence or pelvic pressure or any of those things that we see, like you said, 6 weeks or more. And so I was coming in with that outpatient mindset of knowing I've treated, women 1 or 2 years or more down the road who have just had impairments that were just left unchecked, if you will. And so I was coming in from that standpoint, but the evaluation in a hospital setting is very different. Even though in my mind I'm trying to prevent, in that moment, I have to address what's in front of me. And in every case, and I want to say really honestly, 100% of the cases, mom would be at about a 45-degree or more angle in bed without anyone having told her, you may want to lie a little bit more flat so that your incision isn't really folded at the crease of your hips. Where cesarean incisions, depending on the surgical technique, are really in that area where we sit. And so if I had waited too long, say after 24 hours, and I waited until the second day, she's really been in that position now for 2 days. It's very uncomfortable to now stretch that surgical tissue. But if I was lucky to see her within the first day, the first 24 hours, I would primarily ask, had anyone, told you to lie back so that you're not in a lot of pain and a lot of fluid isn't building up? And I would get 100% of the time, no, no one's told me that. So I would take that opportunity to educate on why it's actually beneficial to really allow the muscles around your incision, the tissue around your incision to relax, because right now it's folded and you're accumulating a lot of fluid and that swelling that needs to go down so your uterus can shrink. You're really hitting an obstacle, which are your hips, which is this bed that's folded. Your eyes would get big, and they would think, well, aren't I going to, tear it apart? It isn't going to hurt. I said, not if we go slowly and gradually. So that would be the first big lesson, the first big education point that I would cover is incision protection and healing. So we would lie back and I would get her to a point where we could go 30 degrees, 20 degrees, 15 degrees. And sometimes we had a bed that showed the degrees on the side of it so that she could actually see on her side and I can see on the outside. Or if her caregiver or her significant other was in the room, I could coach her through it. Because really and truly, the cesarean section is done with her completely flat on her back. Then almost within the first hour, she's brought up into that flex position and she stays that way throughout her whole hospital stay. So that was really a big point that I would educate the physicians on and educate the moms on, because we would never allow, say, a fresh knee replacement to just rest over a pillow the whole time for the first 6 weeks. But we were not educating moms on positions that would actually help them transition to their bed at home. And after that, I could really work on breathing techniques, getting in and out of bed safely without hospital rails because they didn't have that at home. And then really get into vital signs, measuring them before we moved out of bed and after we walked around the room or even went up and down stairs to make sure she wasn't at risk for postpartum preeclampsia or any hypertensive disorders that we would sometimes see be readmitted back to the hospital.
I think it's I keep picturing anything else. Like you use the example of an orthopedic surgery, and you can just imagine, like you said, if that person had had their knee replacement, they were left in the room with a pillow under their knee in a comfortable flexion. But then we didn't see them for 6 weeks. They're discharged, you have to get up somehow. You get home and figure out your stairs somehow, but we would see the effects of that, how hard it would be to achieve that range of motion, or how hard it would be to achieve that strength. Or maybe they've already created some bad habits around limping or what have you, because they haven't been given that early education. And you hear so much people talking about, okay, what do I need to do for my scar? This starts way before, because as you mentioned, whether it be decreasing swelling or allowing the tissues to heal in a more lengthened state and not so much a compressed state, so that just the mobility and learning how to deal with swelling, it can go such a long way compared to dealing with maybe some adhesions or some scar tissue down the road, right?
Oh, absolutely. Absolutely. And we would speak about scar tissue mobilization, but I would give the education that you have to wait until the tissues heal, but you have to even look at your scars. Some of these moms had not even wanted to
Mm-hmm.
use their phone or use a mirror to see their incision yet. I had at least a third of the cesarean sections that I saw were primary emergent, meaning these were moms that were fully expecting to have a standard delivery, a normal delivery, and they were rushed to C-section. So not only were they in shock, they were extremely scared to just even look and reconnect with that scar. And so I started to think about our outpatient pelvic health therapist. How can we even teach scar tissue mobilization or skin care to someone who's this afraid for 6 weeks to even look at their scar? So that was a big point when they were able to lie back flat. Then I would ask them, "Would you like me to use your phone to show you?" And their support, maybe it was their mom in the room, maybe it was their significant other. But they would also be encouraging, and in that moment, they would could actually say, "This is not so bad. This actually is more comfortable lying back like this. I feel like a relief. I feel like I can breathe." And then they would allow me to take it to the next step, which is reconnect them with what happened to their body.
And I think that, what you bring up, I can't help but acknowledge that I think there's a big misunderstanding about what we do offer as therapists after. I think there's this, I always say this misconception that we're standing at your door saying, come on, let's get at it. Exercise. And I think that's kind of, you hear, oh, don't see the physio for 6 weeks. And I find myself saying, no, 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 see us before, because this is what we do so well is, we pre-op a lot of these patients in order to help them understand what's coming, understand the plan, understand that we'll be there. I picture the people that have had open heart surgery and can like the fear of having like, oh my gosh, my sternum has been cut in order to access my heart. But we explain, okay, these are some of the strategies that you'll hear us talk about after. We're going to ask you to hug your pillow. We're going to ask you to do this when you cough or sneeze. We'll show you how to get up like this. And it's very much at the beginning about education, learning to rest and gently starting your mobility in a safer way. It's not like, come on, let's get some push-ups in. Let's start some jumping jacks. But I think that is the misconception about what we have to offer the postpartum client. It's usually, oh, stay away from the physios. They're going to push you a little bit too much. It's very much the same for, I find that most of my education with my postpartum clients is actually I think we need to rest a little bit more. I think maybe you need to spend a bit more time horizontal. You're describing a lot of swelling or pain. I actually think you need to rest a little bit more. And you know how you're having this pressure or pain at the end of the day? This is similar to you being on your knee too long after you've had a surgery. And so I think, again, you're pointing out so many things that we have to offer that are helping you recover and heal so that you can tolerate more load or progression later. Yeah.
Yeah. Melissa, you're so right. And I think that disconnect really comes, I'm going to say this unfortunately, because I work with so many great OBGYNs, but it's really, I think, primarily with the OBGYN midwifery teams that we work with, there's a disconnect with what physios can do earlier after birth. And I say that specialty specifically because I've never seen such a problem with our orthopedic physicians. I've seen them with oncologists, and I've addressed that at the beginning of this talk of what I needed to do to change that culture. But we've been working with oncologists for a while to prepare our patients for cancer-related surgery and treatments. But OBs, for whatever reason, as physios, we have not really, I don't think, educated them on the earlier techniques that we can really implement within the first 6 weeks, not after 6 weeks. And so the orthopedic physicians, they know if they use physios early on, their outcomes skyrocket. Cardiologists, if they use physios early on in the acute care setting, their outcomes skyrocket. Those patients are ready to return home. And so, like you said, with the splinting techniques, that was a big, huge part of my evaluation on that first day was to use actually hospital blankets, not pillows, but hospital blankets within a pillowcase, and allow that pressure and compression to help with pain mitigation, with coughing, because their ability to, and I'm going to use a term here, incentive spirometer. Do you know what that is?
Absolutely.
Yeah. So their ability to use the incentive spirometer was just as impaired as someone after a cardiac surgery, believe it or not. And you have an open abdominal surgery as large as a cesarean section. And for your audience who may not be familiar with how invasive a cesarean section is, there's two main techniques that I've seen it performed where the uterus is actually taken out of the body, or there's a device that allows the surgeon to work on the uterus, open, and then deliver the baby with the uterus still in the body. And there was a huge difference in terms of patient's function, their pain, their ability to breathe, to actually make a change on that incentive spirometer to see how much their lungs could function, whether or not they had their uterus really extracted, pulled out of the abdominal cavity, or whether or not it was in. And so there's just so much to know and learn about the actual surgery itself that really has solidified in my brain. OBs really need to use physios earlier, just like our orthopedic physicians, our cardiologists, our neurologists. Say if someone had a stroke, they really need to make use of us to see their outcomes really change.
I have a couple things that to comment on that you said. I can't help but think too, similar to when we talked about kind of people thinking about their scar tissue down the road, and how we're saying right from the beginning you can make positive, positive changes or think about things early on. Um, Same with the breathing, is I don't think that we realize, like, people are always concerned about when I address my core in 6 weeks or 8 weeks. Your diaphragm is one of your core muscles. And even just thinking about the better I breathe, the better my oxygenation, the better my circulation, the better my healing, the better my core starts off feeling more coordinated in a gentle way. This is all stuff that can be addressed from the early stages. And we have this very much kind of watch and wait, and hope for the best after, and then consult physio if there's a problem. And I don't know either. I think I mean, pelvic health and women's health, I think, is just a little bit newer. Is one of my takes on it, is that maybe we're just kind of learning about that. But I think also too, if you do make that parallel, the orthopedic surgeons or the cardiac surgeons, they probably really don't know what we do. Does that, like, they know that we are their, like you said, we're their ally, we're going to help their outcomes. And they learn in their training that you consult physio at, the generally the physio takes care of this. I don't know if you ask them if they'd be able to tell you what we did. But there's a trust, right? And I think that I have really respected, because I think we have an amazing group of gynecologists in town that are young women that are really referring to physio, but they just still don't know what we have to offer. And I'm trying to just be patient. And I think that things like this podcast are a way, I interview them for different things. And I hope that they listen to these episodes, because I think that we just have to be patient. And just like anything, you have to or have a relationship with someone to have the time to be able to make your case, right?
You're so right, and I'm laughing because you're right in saying that a lot of our physician groups don't know what we do, and in a way that is okay. The presentations that I've given in the past, where I'm actually showing their patients, after I've gotten that consent, I would actually show a lot of videos of what I'm looking at when I see someone walk in and when they've developed a very abnormal gait pattern, where they're leaned to one side. In an in-service, I would actually tell the physician, you might have never caught this because when you come into a room, they're already sitting down, or you've not actually seen them come from the office. So you might not actually see how someone looks with chronic pelvic pain, or something that's affected their spine now, or something that's affected the way they walk and move, because they're sitting down when you come in. And so, part of that really is just that trust that you said that needs to be established.
Yeah, I think that goes both ways. There's a lot of things they do that I don't know either, and I think it does come down to kind of trust and having that relationship. And so I am going to be patient on that. Um, so I wonder if what kinds of things then are happening since you wrote the commentary. Are you involved, or are physiotherapists or physical therapists in your hospital involved for every patient after C-section now?
So there now what I've done in that hospital in Texas has actually been repeated when I moved to Colorado. And now I'm in another state. I've taken a position as an associated faculty at a doctor of either physiotherapy or physical therapy program. And so what I've done now is I've moved more into an education role, and I am teaching occupational and physical therapists how to implement the same programs that I was able to do across two different states here in the United States. And so now I have more of a kind of a broader reach because I can teach therapists who are both, and I'm not sure how you refer to occupational therapists in Canada, but at least physiotherapists who are in the acute care setting. They don't have a pelvic health background, but they are in that setting already seeing people after gallbladder surgery or hernia repair. And I'm teaching them to have those skills to see the populations on the obstetric unit that might have unexpected blood loss or are not safe to walk with their baby in their arms or are not ready to return home. And so, to me, the experts in this phase of recovery after birth are those who are already working in the hospital setting.
Absolutely. I couldn't agree more. I wonder, can you talk a little bit about that? Because I do know that you offer courses, and what does that look like? So are you mostly doing your education towards a whole physiotherapy and occupational therapy department at a specific hospital, or what does that look like?
Right now, I'm doing it for individual acute care therapists who find my course. And the education, it's intended to really expand to hospital settings. It's meant to educate a whole team, whether that team consists of the OBs, the NPs, the nurse practitioners, the midwife groups that might be affiliated with that hospital. But right now, it's to individual therapists who, like myself, recognize that there is a care neglect issue. When I say care neglect, I use that very carefully because neglect really sometimes sounds like it's intentional, but ethical based practice really is unintentionally leaving out a group of people from care or services that their surgery or procedure warrants, and only because we don't know that these services would be beneficial to them. So before lactation services really became standard of care in most hospitals, well, we had to go through that process of understanding, well, the OB nurse can't do all of this, can't provide all of the education that's needed. We need to really start to offer specialized services from these experts in these areas. And right now, we're in our infancy in really educating everyone that we're experts when it comes to acute recovery from a major procedure.
I'm really listening to what you say, and I would say I have a good relationship with different health region administrators in my community or with different physicians. But I mean, the hospital is so full, and there's so many things going on. And I I wonder kind of the best steps, if you have any suggestions for people listening, because there'll be so many practitioners listening to this. And I wonder if you have suggestions to us of the first steps that we can take. I mean, I think just having conversations and maybe suggesting they listen to this episode, but do you have any suggestions for people listening as to first steps they can take to start the conversation of what this might look like in their community or their local hospital?
The first step I took was actually speaking to a nurse manager or a director of nursing and really just introducing the concept as clear as I could, like I am doing with you, is telling her or him what I saw, what I've been observing, where we help out in other aspects of the hospital, with those general surgeries, what we might see, and then just listening to what they might be having as a pain point, if you will. There's a lot of listening that takes place when you're first forming a partnership or a relationship, and you know that. And so, if you allow really people in the field to just speak about how discharge might be held up because moms are in a lot more pain, their pain is not being controlled, or there's this issue or that issue, and if you just offer, wow, well, this is an area that we could actually help in, we can evaluate them within the first day so that it doesn't interrupt your discharge, whatever it is that they're really concerned about. A lot of times in the obstetrics field, they're really concerned about discharge, making sure that they can open a bed so that another person can use it. It's a very high volume area of practice for hospital care. And what I do is really just start with the person who would be in charge of either education so that I could provide an in-service to the nursing staff on safe ways of doing bed mobility without a hospital rail, because nurses may not take the time to lower the bed all the way flat and to remove the hospital rails and really teach their patients how to transfer before they leave to go home. So it's really just listening. That's my first step for anyone who wants to really serve this population in a more meaningful way, is to really allow the person who's in that field, who's in charge of the team, who's providing care, to let them tell you what they need and what they see as an area of need.
Because at the end of the day, I think we have to make sure we approach this not with, I have to add to your to-do list, but more, how can I help the process? Because I have a lot to offer. I think a lot of hospitals and healthcare systems or regions are feeling very overwhelmed. So I think if we come at this from, let me add something to your plate, it's going to be met with some resistance. So yeah, I think, like you said, I love the idea of just conversation and come up with, just a starting point. How can I help you? Right.
I
Will you,
agree.
will you talk a little bit more about your course? Because what does it look like? Do people work through it on their own? Is it something that you facilitate? Where can they find it?
The course, as everything, is in its infancy.
Yes.
I've been offering it online, live training, completely me during the whole 15 hours with the clinician. In the course, I have gotten now so much feedback over the past year that the amount of information that's really covered, they would love to go through it. They would love to take what I said and then hear it again. So I've decided in 2023 to make some of the content asynchronous so that they can actually go through the material and really learn. I mean, we cover things like the growth of the uterus and why that's important to know, the change of circulation, how much circulation now is moving through the maternal fetal system, and why after delivery or why after a C-section, the risk of hemorrhage is so high, so that they have to know if someone has actually experienced this type of blood loss, what outcome measures to use so that they're not walking and at risk of collapse. So we really go into the physiology of just not only the birth, but what it looks like within the first 72 hours. And so it's really geared towards those practitioners that are going to be working with moms either in the hospital setting or in the home. So a lot of our courses here, at least in the United States, are really geared for the pelvic health therapist population. And that's really kind of why my commentary was almost not published, because one of the reviewers was adamant that it really was for women's health. And I had to really educate on that this is more of an acute care area of practice, because these are practitioners that know how to assess vital signs and really mitigate symptoms and respond in an early way before that person goes home and finds themselves in trouble. And so the course is geared towards occupational and physical therapists, physiotherapists. I've actually had quite a number of attendees from Canada as well. And it's really geared towards their communication. So we do cover techniques, we do cover interventions that they can do within the hospital setting, but we cover and go deep on how they can actually approach care teams, provide in services, and get a program up and running. And a lot of it has to do with their communication, their ability to really emerge as a leader. So it's really turned into quite a fascinating transformation to me as a course director in understanding that I'm actually helping to facilitate leaders in this space, in the acute care environment, that are not being identified as pelvic health experts, but are being identified as birth experts, at least in the early stages of recovery.
I can't thank you enough for, I can just imagine the number of hours you've put into this, the sleepless nights, the the frustrations. And so it takes a special person to really champion this. And so thank you.